Okay, well, good afternoon to everyone, and thank you for joining us for our December edition of our Public Health Forum for Healthcare Providers. You may have noticed the new name. We will continue to focus on all the MPOX information that comes out, but we also wanted to offer an expanded scope to other things that we hope will be of use and interest. We've also moved this meeting to once monthly instead of bi-weekly. But of course, if any other emergent or important issues come up, we will adjust that frequency as it is needed. I know no one comes here to hear from me, so first up today, we have our one of our chief physicians here, Dr. Latasha Gale Lowe, to deliver our public health update.
Good afternoon, everyone. First of all, on behalf of our Public Health Authority, Dr. David Purse, and our Deputy Public Health Authority, Dr. Janina White, I wanted to extend a warm welcome and say happy Friday. Thank you all for attending. Basically, we want these meetings to be meaningful and useful as you all are caring for your patients. So as a reminder, our COVID data is on our website. And most recently, our well water positivity rate data mirrors our test positivity rate, which is around 8%. That information is available on our website. We also are seeing flu, and that information is located again on our website under quick links. And the last report listed is November 19th. Those are just our quick reminders, and we'd like to turn it over to our next presenters. And thank you so much, Roger.
Yeah, thank you so much for being with us, Dr. Lowe. So next up, we have one of our regular updates on MPOX from Kirsten Short and Komal Sheth.
Hi, good morning, everybody. Let me go ahead. Let me go ahead and get these slides set up for you. So just one moment. Push this down. There we go. Oops. All right, is everybody good? You can see the slides?
Yes, ma'am, we got you.
Okay, so let's go ahead. Good to see everybody again, or be back with everybody. As you know, this is what we normally update on about monkeypox status. Let's start again globally and move local. So at this point, there are over 81,000 cases reported globally, and this has been an increase of about 3,000 to 4,000. With the US has the largest number of cases, again, followed by Spain, Brazil, France, Germany. Globally, we are up to 59 deaths, with 15 confirmed monkeypox deaths in the United States. Most of these deaths are occurring in people with compromised immune systems or other healthcare challenges. Yeah. The United States is up to a little bit over 29,000 cases. And Texas, one of the changes is that Texas, we are now the state with the third highest case count, preceded by California and New York. Previously, we had been the fourth, so we've now outpaced Florida in terms of the total number of cases. Here's our national epicurve. We continue to see that the large volume days of this outbreak are behind us, but we do have this long trailing tail. So there's still transmission occurring, and we do still need to keep up our efforts. When we look at testing at the national level, we see that the cumulative positivity rate continues to hover and is right here around 27.3%. It's really been fairly stable over the last few months with a slow decrease, but ranging from about 16 to 26%. But as the total number of tests drop down, that testing volume increases and those who are getting tested changes, that percent positivity does become a little bit less reliable. If we look in the US at our demographics, that's again continuing to remain stable. They're male, they're young, young to middle-aged adults, but we do continue to see that Black population right now is persistently disproportionately affected. So we definitely still have work to do within the equity arena. If we bring it down once more into the Texas level, Texas has over 2,800 cases. Most, again, are between the ages of 18 to 49. Almost all of them are male, and they do continue to cluster, not unexpectedly, in the metro areas. Again, the Dallas-Tarrant County, which would be Region 2-3, and the Houston-Galveston area, which is 6-5 South. And within Texas, Houston accounts for a quarter of the cases in Texas. So now I will go ahead and turn it over to Kamal.
Thanks, Kirsten. Hi again, everyone. So I'll go ahead and talk a little bit about the Mpox status specific for the city of Houston. So data as of this Monday, November 28th, the current 7-day centered positivity is actually showing as 0%. But, to mirror what Kirsten said, positivity rate can be unreliable with low testing. We are still seeing, like spots, cases popping up sporadically, but the centered positivity is 0%. Next slide, please. When looking at the new cases over time and the cumulative case count, you can see that in the past few weeks, we are seeing very few new cases popping up, as mentioned, and that this cumulative case count curve has been flattening steadily over the past couple of months. So we are moving in a good direction with that. When breaking down by demographics, similar to before, the city of Houston demographics for the Mpox cases do match or mirror what we're seeing nationally and statewide, with most cases in that 20 to 39 age group, most cases primarily in the male population, similar demographics by race and ethnicity. And the case count as of Monday was 708 cases. Spatially, again, it's been pretty stable over the past few months, where we're seeing, again, most of the cases in that midtownish, downtownish area, and a few further out in like the West U area. But again, spatially, things have remained pretty steady over the past few weeks. When it comes to vaccinations, there are currently 8,290 individuals who have received at least one dose of the Mpox vaccine, and about 5,400 individuals who have completed that series. So that's about 68% of individuals who are eligible to complete their series have completed their series. And there are just under 2,300 individuals who are past due for their second dose. So they are more than 35 days out since their first dose. As expected, and as before, almost all the vaccinations are among the male population, and the majority of the vaccinations are in that 19 to 39 years age group, where we're seeing the most cases. When looking at it by race ethnicity, we are still seeing similar trends as before, in the disparity where Black African American populations are accounting for about 38% of Mpox cases, but only account for about 16% of vaccinations. And Hispanic Latino populations are accounting about 33% of cases, but only about 29% of vaccinations. So as Kirsten mentioned, still some work to be done there. And lastly, when looking at the overlap between Mpox status and HIV, we see about 40.3% of Mpox positive individuals are also HIV positive, and about 22.8% of these Mpox and HIV positive individuals are not currently virally suppressed. And so that might be causing, it might be a little harder to reach them for vaccination because they may not be seeing their provider regularly. And I think that's it for the current updates we have for Mpox status. Thank you.
Hey, well, thank you both. I always find those statistics very informative. It certainly shows that we've come a long way, but there's still a lot of work for us to do as a public health community. Next up, we have Dr. Abisola Oladimeji. She is the project lead for our Mpox investigative unit, and she's going to be providing some information on some of our lessons learned from Mpox in congregate settings.
And thank you, Roger. Good afternoon, everyone. Let me get my slide projected. Can everyone see my screen?
Yes, ma'am.
Yes, I can see.
Great. So good afternoon, everyone, and thanks for joining us once again. My name is Abisola Oladimeji, and this afternoon I'll be taking us on monkeypox or Mpox in congregate settings. And while 10 minutes might not be enough to do justice to the topic, we'll be focusing on what our response has been in some of the congregate settings within the city. And as providers, we wouldn't be talking about, oh, what's the clinical expectations rather, or case definition, rather will be asking for what on the public health aspect would be expecting from you, and also list some services which HHD continues to provide during this response. And as earlier speakers had mentioned, while we are having declining cases, and while monkeypox had not been a novel disease to everyone or to anyone, the presentation for this outbreak had really been novel in terms of the population affected, even the geographical spread, and also when we look at the skin lesion distribution of individual patients. So this, I wouldn't keep us on this. We know monkeypox is self-limiting, and that's not removing from the fact that it really caused real high morbidity and sometimes mortality in immunocompromised individuals. But I want to call our attention to the reproduction rate, which is also known as the R0. For this outbreak, it's stated that it's less than 1, and easily we can look at that and say, oh, this is of course not of significance. But when we look at a congregate setting where people actually interact on a closer proximity compared with the general population, would understand why it's still of public health importance. And quickly, to just show us a couple of congregate settings that exist. We have both medical and non-medical congregate settings, which range from our nursing homes, assisted living facilities, correctional or detention facilities. We have our schools as well. Places of worship are also congregate settings. And we also have social settings, including even our workplaces. Now, going straight to the cases we manage from some of these congregate settings, I would talk about the case we had from the skilled nursing home around middle of October. So to take it on two of these cases, in October 17th, we received a report of a suspected case, and the next day we were able to detect that this individual was orthopox positive. The client actually was a staff of a skilled nursing home. We conducted in-depth interview and identified the source of exposure for this client, and also elicited contacts for this client. Patient had direct resident care prior to detection of lesions. And we also identified both high and risk exposure contacts to about 80 of them within the facility. HHD was able to provide guidance on isolation and facility infection prevention control measures. And HHD was also available to support the staff and residents with vaccination, both the first and the second dose. We followed up with the client till clearance and return to work. And when we say return to work, this is all the skill lesions healed and new layer already formed. For the second case, which now is a pediatric, is a less than 10-year-old kid, elementary kid, who initially was being followed up as a contact to a household case. So this kid was found to be eligible for vaccination and was actually undergoing a pre-vaccination assessment when 2 skin lesions were detected on the back. So a pediatrician review was requested, and at the time of assessment, the lesions at the back were already scabbed off and already healing. But deeper examination and evaluation revealed a tiny lesion on the little finger of this kid, on the right little finger. And this was the only lesion that was swabbed and then sent to the lab. And we wouldn't say expected, but then we were surprised to actually detect our first pediatric case that lived and also resided within the city of Houston. And so what did we do after this? After talking with the household, the legal guidance for this child, and understanding that we've been working with them prior to detection in this kid, because a household member was positive, it was easy for them to understand where we were coming from. So we had to reach out now to the school community, inform the school nurse and management team, and supported the school in sending communication to the school parent community and also the general community. We also identified about 30 school-related contacts, and the intermediate exposure risks were recommended for post-exposure prophylaxis. Monitoring is still ongoing, and I'm glad to say the case is returning to class, I think today. But we still continue monitoring of the identified contacts. So what are our expectations from healthcare providers in such situations? Knowing that the cases of monkeypox are actually declining, and knowing that we have had a particular population most affected, we would advocate for more or a high index of suspicion to still be maintained among our patients, or when we're evaluating, still elicit history of contact, and every lesion should still be looked at with a high of suspicion. Also, school nurses or vaccination centers, we partner with TCH, might request a pre-vaccination assessment to evaluate this kid and to concretize on the kid's eligibility for vaccination. And also schools do request for doctor's note when it comes to ending of isolation. So to be sure that this kid is fit and can return to class without being at risk to other kids or even teachers. Would also request that sample collection still be done. When we are not sure of what the lesion is, we should still go ahead, let's swab and send to the HHD lab. And as I mentioned earlier, there's still a need for doctor's note for this kid or even staff of the school or congregate setting. From the HHD standpoint of view, we'll continue to support with testing, and also, should we have clients that have a need for tecovirimat, which is TPOXX, we'll be supporting with linkage to dishes, which is who is coordinating this at the moment. Vaccination is also still available with the Houston Health Department, and we will continue with the support with case investigation, contact tracing, and monitoring. For further resources, you can please visit these websites. And that brings me to the end of my presentation. Thank you.
Awesome. Thank you for that information, Dr. Olademeji. The last presentation we have for today before we get to the question and answer session, we'll welcome back Kirsten Short, who will be talking about notifiable diseases and conditions.
All right. Good morning or good afternoon again, everybody. Here to chat with you a little bit about our notifiable conditions. So let's go ahead and get started. All right. So why would we talk about disease surveillance? So the public health system really depends on reports of diseases to monitor the health of the community and to provide the basis for public health action. Prompt reporting by mandated reporters, including physicians, laboratory scientists, and other healthcare professionals, both of diagnosed and suspected communicable diseases, can allow for timely action by local and state public health. It's a teamwork effort that makes possible benefits for patients and for the communities that can include our ability to identify outbreaks and epidemics. If there's an unusual number of cases that occur, local health authorities, we can investigate and implement measures to control the spread of disease. Dr. Abby just gave a really great example of some of the things that we're doing around that with monkeypox. This also allows us to enable preventive treatment or education to be provided, again, something that we've been doing throughout this outbreak, to help target prevention programs, identify needs, and use resources, particularly when resources are scarce. And again, as we've been going through this outbreak and going through looking at what is the population of those that are getting ill, where are our vaccines going, and where do we need to put more effort into to evaluate the success of prevention and control efforts, to comply with Texas's public health laws and regulations, right? So all public health providers and labs, as well as other entities such as schools, are required to report certain cases of communicable disease. And then finally, to assist with national and international disease surveillance efforts, right? So Texas is just one state, part of a national network across the United States that the federal government depends on to determine whether national or international investigations are needed. And accurate and complete disease reporting is essential for the community's health. So let's talk a little bit about this. If you have talked about reporting before, you might be a little bit confused because there is both a national list and a state list. So the national list is sent by CDC, the Centers for Disease Control and Prevention, and CSTE, which is the Council of State and Territorial Epidemiologists. That's the professional organization that helps guide the work that I and others do. So the national list includes about 120 conditions. These can be infectious diseases, they can be bioterrorism agents, sexually transmitted infections, and also chronic and non-infectious conditions. And then each of these conditions has a case definition, which are requirements that are identify whether it should be reportable or not. And reporting on these conditions is requested, but not required. I mean, when we come down to the state list, these are set by state health departments. So in our case, that would be the Texas Department of State Health Services, or DSHS. And the Texas list has about 75 to 85 conditions, depending on how you define them on their list. Most of these are infectious, but not all of them. Some of these are reported and covered by local public health. Others are covered by state public health agencies. And state conditions do not have to be on the national list. So before I go any further, I do want to talk about what is sometimes folks get a little bit excited about. So what about HIPAA, right? So as a medical provider, you might be completely on board with the framework behind why to report to public health. All of these things I mentioned might make sense, but either you or your facility's risk management staff might be like, whoa, what do I do about HIPAA? And I really want providers to be cautious about releasing protected health information, but HIPAA does include provisions for public health reporting. So the privacy rule within HIPAA allows for the disclosure of protected health information without individual client or patient authorization to public health authorities who are legally authorized to receive such reports for the purpose of prevention or controlling disease. I've got some links below that you can go to at the national, the government's HIPAA website, talking about just generally special topics, and then specifically into public health if you have any concerns. But HIPAA should not be something that prevents you from reporting or delays you from reporting into public health. So let's come back and talk about notifiable conditions in Texas, right? So as I mentioned, there's this national list that CDC and CST create, and then states determine what they want on their list and have the option to include additional conditions of state importance. There are several sections within the Texas Health and Safety Code, specifically inside of chapters 81 and 97, that guide reporting in Texas, from healthcare providers, labs, schools, and other entities. So this slide might look a little bit familiar from the Ebola presentation, but generally I want to talk a little bit about who do I report to. So reporting is generally determined one of two ways, either by patient address or by facility location. When in doubt, reach out to your local or your regional public health office. We are very much used to routing information to the correct jurisdiction or the correct area if need be. We do not expect, if you have a visitor come into your office from Connecticut, let's say, ends up being diagnosed with a notifiable conditions, we don't expect you to know how to get in touch with Connecticut's health department. You can simply report that to your health department, and then we'll make sure that it gets to the right place. So let's go back to the notifiable conditions list. Within Texas, there are, over 70 conditions represented on the list. It's going to include arboviral diseases like West Nile virus, enterics like salmonellosis, drug-resistant conditions that we're concerned about like Candida auris, vaccine-preventable diseases like pertussis or hepatitis B. It also includes non-infectious conditions like elevated blood lead levels or spinal cord injuries. Reporting priority ranges from red, which would be those call immediately. Those are conditions such as smallpox, Ebola, measles, botulism, Neisseria meningitidis, over to blue, which are report within 1 workday, and then to black, which is generally report within 1 week, although some things do have longer time frames. Usually you're going to report to your local or regional health department unless it's otherwise noted. But in addition to things that are specifically listed on here, there is a clause at the bottom of this, and you can't read it very well, which is why I put it over here on the right-hand side of the slide. So this says, in addition to specified reportable conditions, any outbreak, exotic disease, or unusual group expression of disease that may be a public health concern should be reported by the most expeditious means possible. So this phrase is really helpful and important. It gives us the authority to investigate and y'all the authority to report things like influenza outbreaks, gastrointestinal outbreaks, things where the causative agent isn't known, or things such as monkeypox, which aren't on the notifiable conditions list. So let's talk a little bit about that clause for a moment and focus on the outbreak part of it. So outbreaks don't have a single definition. It really is dependent on what you're talking about. So it can sort of generally be an increase in the number of cases above what you would normally expect in a population over a period of time. It could be 2 or more cases of a similar illness resulting from an ingestion of a common food product. That might be a definition of a foodborne disease outbreak. Or it could be a single case of something such as pulmonary anthrax, smallpox. If you recall, from the current Ebola outbreak coverage, Uganda did declare an Ebola outbreak back in September when they had their first case detected. Now I want to talk about that same clause, but focus on the unusual group expression of disease that might be a public health concern and give you an example of how this can work. So back in September of 2018, we received a report from an astute clinician, who is my favorite type of clinician, of 3 patients who were admitted to a local Houston hospital with bloodstream infections. These bloodstream infections in and of themselves were not conditions that required reporting to public health. But when the clinician conducted the interviews with the patients, all 3 had received non-FDA approved umbilical cord stem cell product procedures at the same clinic. So this really gets to that idea of a group expression of disease that may be of public health importance. So this prompted a response from our Healthcare Associated Infection Program, or HAI program. We reached out to CDC for consultation. We worked with our state health department, as well as a few other area health departments. Ultimately, this investigation expanded into multiple states. There was product testing that was done, which identified that there were actually bacterial contamination of the stem cell product, and it was voluntarily recalled. CDC ultimately involved FDA, who inspected the manufacturing facility for this product and found deviations in the requirements for process testing and screening of the products. And ultimately, legal action was eventually taken at the federal level. Right. And so I think this really goes back to what we're talking about at the beginning, why disease reporting is important, why it's important to understand what those boundaries are of what you can and cannot report without liability. And again, encouraging y'all to reach out to public health whenever you have concerns about something. So thank you so much for your time. That's the end, but I am very happy to come back. If you have specific questions or specific areas, please feel free to share those in your feedback, and we can certainly talk in any more detail about any of these pieces.
All right. Well, yeah, a big thanks to Kirsten and all of our presenters today. We'll move on to any questions and answers that may come up. And I will point out that this presentation will be available on our website within the next couple of days. All right. And I'm not seeing anything in the chat. If anybody wants to chime in with a question, I'll give it a minute or two before I cut it off, if nobody has anything. Okay, I do see a hand up, Vince.
Yeah, thank you, Roger. Thank you to all the presenters. My question is, the first presenter, what exactly are the strategies being done to rectify the difference between those that get the first shots of the vaccinations and then those that fall behind from the second shot? I can see that it is a considerable percentage among those that get fully vaccinated and those that only got the first shot of the vaccination. Is there any strategy from the HIPAA immunization section? I would like to know what they are doing to rectify that difference. Thank you.
Sure, I'll let anybody who wants to chime in on that answer, but I will, speak to the things I know that we're doing. So first, our, overall completion rate is around 68%, which I believe is significantly above the national average. So we're very proud of that. But we are sending out lots of mailers to remind people to come back and trying to just remove as many barriers as possible to making that second shot available. I don't know if Kaylin or anybody from the immunization team's on that wants to chime in or add to that. No? Okay. And then I do see in the chat as well, can we provide the PowerPoints? Yeah, anybody who would like to have a copy of the PowerPoints, I'll tell you what, just send me an email, roger.seeley@houstontx.gov, and I will be happy to provide those. And see, Kirsten's put them in some of the chat as well. Okay. Any more questions today? Okay. I don't want to take up anybody's time unnecessarily. Everybody's time is valuable. So if there are no more questions, we'll just go ahead and close out this forum. Thank you all for attending. The next one will be the first week in January, and I will send out the agenda before that. Thank you very much.